again, and I invite Professor Rohit Saxena, the Secretary of AIOS, to be presenting his talk on disc edema, approach to a case with disc edema.
Thank you, Digvijay, and of course, thank you for the opportunity. Can I have a pointer, please? Pointer, if possible. So, disc edemas has so much to tell, so little time, so I'll just try and run through whatever. Key approach, at least that's the way I would work up, is firstly identify whether it's bilateral or unilateral, because the causes tend to be different. Of course, for unilateral, the other important thing to know is whether what's the status of the other eye. So other eye could be normal, there could be edema, or it could be atrophy. So all these things are important to know. In fact, the dictum goes that if there is poor vision in one eye, you actually need to worry about and more extensively evaluate what you believe is the normal eye. So bilateral, you're looking at pseudopapillodemas, papillodemas, hypertensive retinopathies, bilateral papillitis, compressive neuropathies, which more often than not require more systemic and neurological workup. You have unilateral edema, you have hyperemic eye, you have more of inflammations, demyelinating, pseudopapillodemas. You have a pale disc, there is a pale edema, there is a possibility that's ischemic in origin. And if you have optic atrophy, either it's tumor you're worried about, or else the event that's happening in this side today happened in the other eye some time back. So key important thing, you have bilateral disc edema, you need to look for papilledema versus pseudopapilledema. You need to be sure whether it's true or just appears to be edematous. So the key signs would be obscuration of vessels, clear edema. So a lot of times small children with hyperopic discs are referred, extensively investigated, LP is done, repeated imaging is being done, and they just have hyperopic discs with mildly blurred margins. So you need to be very careful. The cup is obscured, the vessels have to be obscured, and whenever in doubt, follow up the child after a week or so. If it's progressing, you are going to start seeing an increase in the blurriness, you're going to see an increase in the obscurations. So you can classically see the difference that is there. So while it appears to be edematous, you can see that the margins don't seem to be sharp, but there is an absence of cup. You can see the vessels are pretty clearly visible there. So no hemorrhages, exudates. So that's your first important thing. And anyway, most important thing, please remember, whenever you're assessing the disc, do it in 3D. Always do a 90D assessment of the optic nerve head, never with a direct ophthalmoscope, and definitely not what the retina people are very fond of, the indirect ophthalmoscope. So these are like, 4 key conditions that you would see. So this is pseudopapilledema. You can see the vessel, the margins are blurred. It does look as if there is a bump or a lift here somewhere, but the vessels look pretty good. Here you can see, of course, you have a lot of exudates, you have hemorrhages, splinter hemorrhages here, but the blurred margins, the absence of cup, but the obscuration of vessels. Here you can see the edema, the splinter hemorrhages, they are far away from the disc. So there is no continuous area, there is a normal retina in between. Whereas here you will see, even thus far, you have a retina that is affected. So all this is arising from the disc. Here, this is not completely involved. In this figure, you can see the hemorrhages are away. You have a relatively normal-looking retina in the middle. So this is hypertensive retinopathy. And again, here you can see a lumpy, bumpy disc. Classically, you'll see, of course, on ultrasound or an X-ray, you'll see this calcification here. But you can see the lumpy bumpiness of the disc. It's not looking like clear edema, but there is irregularity of the margin. The vessels seem to be bumping up over the drusen's that are there. But so if you are sure it's true papilledema, obviously patients is going to have signs suggestive of raised intracranial pressure for that would include nausea, vomiting, headache, usually bilateral, although they may be asymmetrical sometimes. And of course, fields may show initially just enlargement of the blind spot and a bit of constriction of the fields, but over time you may have all kinds of field effects as the optic nerve starts getting affected. Imaging is very, very important at the first go because you need to rule out space occupying lesions, and of course if you have an IIH as a suspicion, you must do an MRV, because venous sinus thrombosis needs a little more aggressive and a little more different kind of management. So investigate for raised intracranial pressures. First, rule out a space occupying lesion. Check for pressures, check for sometimes even low grade meningitis can present like raised ICT. Of course, you need to work with your neurologist when you're doing this. Weight loss, as a thesis under Dr. Swati showed, while one of the most challenging things to achieve in life, is definitely very impactful when you are managing IIH. And of course, all the other things, look for drugs that the patient may be having, controlled blood pressure, anemia, CPAP for obstructive sleep apnea, diuretics, but our sheet anchor remains acetazolamide. Surgical options are there. We do optic nerve sheath fenestration if the vision is significantly affected. When you're looking at unilateral, I won't go through all the diseases per se separately, but usually an initial hyperemic appearance would be more of papillitis, sometimes even asymmetric papilledema when the one eye gets involved and the other eye is still waiting to show its effect. Pale disc edema, you would at the very onset start thinking of ischemic optic neuropathies. Thankfully, we tend to see much less arthritic causes of ischemic optic neuropathies, but still that is something that you need to keep in mind. Optic neuritis has been discussed frequently in multiple forums in this conference, so just remember typical and atypical features. You need to now work up more extensively. Imaging has now become one of the sheet anchors for diagnosing and managing and trying to classify the reason behind it. Role of IV steroids, almost now upfront. The moment you think optic neuritis, IVMP is now a treatment that you must think of, even if the vision may be moderately affected, or else especially in view of the fact that the patient may have NMO or MOG, the outcome especially of NMA deteriorates significantly if you delay IVMP. And of course, if there's an atypical presentation, you must think of getting serology for NMO and MOG. Availability, of course, being a challenge in India. When it's ischemic, you think of NAION or arthritic. It's important to distinguish or identify arthritic very, very quickly, because it's almost like an emergency. You need to treat very, very fast. Unfortunately, currently a lot of overlap between NMO, which presents late, and ischemic optic neuropathies is occurring, and that's why sometimes we have to be more aggressive whenever we look at unilateral disc edema with severe visual loss and in a middle-aged or a little older patient, because it still could be a late presentation of NMO, but essentially a little older age group with the presence of systemic side effects, ischemic optic neuropathy becomes one of your key thoughts that you have. Again, the effect and the involvement can be very subtle. You can see the patient had not exactly very significant vision loss, but just a mild pallor, and there was a central ischemic neuropathy that was there. So identify all sort of risk factors. There are a lot of risk factors that need to go. Sleep apnea syndrome, often missed. You need to ask the wife whether the person snores or not, and does she get a good sleep or not. So there is a whole lot of questions you need to ask when you're managing NAION, and unfortunately, till now, there is no clear intervention management options available, the most important only being control of risk factors. As I mentioned, arthritic, important because you need to confirm arthritic, consider GCA, because that requires emergency treatment. This is one of those rare conditions in ophthalmology where 5-year survival rates are discussed. So if you don't treat, or if you don't manage or intervene quickly in GCA, you can have not only the other eye involved, but also the effect happening in multiple other parts of the body and causing an effect. So like I mentioned, arthritic AION is an emergency that you need to manage and require high dose steroids over a long term, sometimes continue up to 1 to 2 years, and you may titrate with the ESR CRP. So just coming back again, it's important. Systemic workup, a bilateral, unilateral, you may be misled by an asymmetric presentation. Otherwise, look for other causes. Thank you very much.